Apologies.
That's quite all right. I would quite happily sacrifice my time to have that last talk extended by another 15 minutes. That was just fantastic, and I really appreciate learning new stuff. So now to the more mundane. Let's briefly run through some developments and innovations in 3 access sites that I've listed here. I've tried to focus on the last year or two. Maybe not everything has been published. Start with the radial. This is some published stuff. So we all know that the radial occlusion remains a problem at a low level, and the 2 primary means of reducing the risk of radial artery occlusion are adequate anticoagulation with heparin and patent hemostasis. One note on the heparin, the recent development, I suspect most of us in the room here will give 5,000 units or 50 units per kilogram, but there has been a randomized trial in diagnostic angiography of 100 units per kilogram versus 50. 1,800 patients, and occlusion was markedly lower, ultrasound detected in the 100 units per kilogram dosage. So that's just pause for thought. Perhaps we should be giving more heparin than we have previously. I will stress that in this study there was no protocol for hemostasis, so patent hemostasis was not mandated. So whether this directly applies to those of you that are practicing patent hemostasis remains to be seen. The second innovation is in the field of mechanical compression to assist with hemostasis, and here's the PROFIT-2 trial run by Samir Pancholi. I want to highlight, first of all, that in blue is what we all do with patent hemostasis, and look at the radial artery occlusion rate over time. So sure, there's a higher rate of occlusion at baseline, but look at 24 hours and at 30 days, a massive spontaneous recanalization of the radial artery. That was hugely assisted by adding ulnar compression, so compressing the ulnar artery at the time of radial sheath removal. Kind of makes sense, right? You occlude the ulnar artery, you divert blood down the radial artery, which likely promotes through multiple mechanisms patency of the radial artery. This is how Sam Pancholi does it. This is his video. So he's locating the radial artery with his finger, puts an old-fashioned watch strap kind of band in the right spot there, rolled up in a piece of 4x4 as a needle cap, just a plastic needle cap, and then he uses that to force pressure onto the ulnar artery with this band, and then basically removes the radial artery sheath. Just notably, he opens the side arm of the sheath to let any blood in that column bleed out as the sheath is pulled away. Perhaps that is also a protective mechanism. And then you leave the radial and ulnar band in place. So that's the way of doing it. So it looks a little bit cumbersome. We know there will be bands. They are in development now, dual compression bands, and perhaps there will be uptake of those. I have to mention the distal left radial. This has really grown, at least on social media, and has been taken up by a number of people. And this is here. This is actually distal radial. There's also snuff box access, which is a little bit more upstream of this. And the reason why this was developed initially was for comfort for the patient, bringing that left arm across while you stand on the right. The arm is in a more favorable position for the patient. But it turns out there may be other benefits, and these are under in study now versus regular radial access. Success rates, of course, hemostasis and occlusion as important safety parameters, and other theoretical concerns. This is an end vessel here. There potentially is a risk of scaphoid ischemia, which may be quiet in the background for a few months. So we'll wait and see if there's any bony risks down the line. But I have to mention this because this is certainly increasing in use in a number of sites. One little tip that Dr. Kiemeneij put out there was this use of a glove on the patient. So the glove is put on the patient, the thumb is tucked on, the glove is withdrawn back. That holds that thumb in place and makes it an easier access point for you to attack. Here is just a fluoro of it, one being done here, and I want to point out the angulation here. It's more challenging, certainly in the early stage of doing this, than a regular radial artery. The vessel is smaller, and there is this angle to deal with, needs some manipulation. If you're going to access with the arm across the body, that does introduce more tortuosity into the upstream radial and brachial, and that may be another challenge that you have to deal with. A couple of cases have been published of, I think, quite innovative use of distal radial access to treat the upstream radial artery. So here's a case of a main radial artery occlusion over here, and the authors access downstream here in the distal radial artery and use their magic to recanalize the radial artery. This has also been used for the endovascular treatment of radial artery pseudoaneurysm, leaving a sheath in place from the distal left radial artery across the radial artery pseudoaneurysm, sending the patient to go walk about for a few hours and bringing them back, and a case been published showing the endovascular sealing of that radial artery pseudoaneurysm. That's kind of a neat idea. So let's jump onto axillary. There's certainly been a marked upward trajectory in the use of trans-axillary percutaneous access for TAVR, large bore sheath placement. I'll show you a case and perhaps some data that's been published in this. So not infrequently, we do see patients who have not good femoral arteries for access, severe iliofemoral calcification, but there's this paradox of a dearth of calcification in the upper vessels. The same patient who had wild calcification in the legs, almost no calcification over here. And a nice axillary subclavian axis for access here. So here's a baseline angiogram of the axillary artery. You can access between these two spots. Most people favor a more central access over a compression point here in the ribs. But you can really access between these two branches. Ultrasound, some people use primarily as a guide to access. Many will use both angiography and fluoroscopy and ultrasound like us. Here's just a store fluoro of an access. You unfortunately do see the hands in the field here, and here's a wire going in as normal. Then the standard sheath percloses are placed, and TAVR is done in the standard manner. Like you see over here. Left axillary is favored, and you can see why this is a right axillary case, and you can see the alignment of the TAVR valve is less favorable than would be from a left axillary approach. Sure, it can work, but left axillary is preferred most of all over the right. So in terms of closure, I'm going to run through these things here. Closure, I can't stress high enough the importance of perfect closure. So one neat innovation here was to use a balloon wedge catheter rather than a peripheral 7 or 8 millimeter balloon, just the balloon wedge catheter. That balloon itself is relatively atraumatic. It's $50 as opposed to, gosh, a few $100s for a peripheral balloon, and that can be used to occlude flow and assist with hemostasis. It's critical to get perfect hemostasis in the axillary. So here is the perclosed point over here, and you do see a little bit of contrast escape over here. After 15 minutes of pressure and some prosamine, that's sealed up nicely. And contrast this to the right axillary, one case we've had here. You do see again a little contrast escape, and I would say that if you saw this in the femoral artery, you might say, well, we'll press for another 10 minutes and then we'll all be done. That's what was done here. Pressed for 20 minutes, prosamine was administered, and look at the next angiogram. So wild escape here of contrast. It's critical that you get perfect angiographic hemostasis from the axillary here. Covered stent was placed. Importantly, one other concern in the background is the risk of an axillary approach. This is TVT registry study, a propensity matched study of trans-axillary versus trans-apical, trans-aortic. And the thing to highlight here was the stroke risk was higher with axillary. 5% of axillary cases had a stroke. Question is there a genuine anatomic substrate for risk from an axillary approach, or is it just because these patients are sick, they couldn't get a transfemoral approach? Right, these are alternate access approaches, and that remains uncertain. I will counterbalance that with this study, which was a series where they went primarily axillaries. The patients had good femorals, but this group goes axillaries their first choice, and their stroke risk was not 5%, it was down closer, although still perhaps a little higher than a standard transfemoral approach. So axillary is growing, but there is this background lingering concern potentially for stroke. In our center, we're using it increasingly for patients who are on the transplant waiting list who require support for a number of weeks while they're upgrading their status. And here's a 7.5 French sheath placed in a more distal access site. So here's the armpit over here. This is really the upper arm. And this has been revolutionary for patients who need to wait for days or weeks for transplant. They can ambulate, walk around. It's been really great for long-term maintenance balloon pump and also for keeping their health prior to transplant, which assists with recovery. Very easy to palpate. You can also see it on ultrasound, and hemostasis is not a problem. There are several nuances to this that I won't go into. My colleague Ata Bayfar has really increased our volumes here, but there's so many little things that make a difference, from the way you put the dressing on, the way the slack that's required to minimize the risk of kinking. You get kinking at this point, kinking in the body. Several nuances, but certainly this is a new thing to look out for. The final innovation, I think, is a real neat tip and trick, and this was provided by Jason Walmuth on Twitter, and I think this is really kind of neat. So this is an impeller, I'm sure you all know, and we need a large bore for this. Well, we need a large bore sheath because it needs to accommodate this, the clockwork end of the impeller. The rest of the impeller, this long tube over here, does not require a 14 French sheath. So Jason's thought was, well, gosh, we have all this real estate in the lumen of this big 14 French sheath with this little twiddly noodle of a catheter up here, so why can't we use this extra space to put in another sheath, a 7 or 6 French sheath, and do your PCI from this single access point? So a 6 French or 7 French sheath inside this sheath over here. The point to note is that if you put this sheath directly alongside the impeller sheath through this valve, there will be severe bleeding alongside this, so you can't do that. What you need to do is to penetrate the diaphragm alongside to create a different hole, and this is the back end of a micropuncture wire, and this is the micropuncture sheath creating a new channel through this 14 French sheath, and you put an 035 wire in, and this is a 6 French sheath that's going directly alongside that. Preferably to use a braided sheath to minimize the risk of compression and accordioning. The best part of this is that's your hemostasis. You pull the sheath out the end and you're all done. Thank you for your time.